Dr. Saurabh Kamal. Saurabh, are you there?
Hello.
He had
Yes.
Yeah, hi. He had a very interesting sort of a study or unrecognized entity, which he's going to talk about.
Can you see my slide?
Yes, it's clear.
Yeah. Can I start now?
Please.
Hello.
Please.
Here. Yeah. So my topic is intranasal cyst in congenital nasolacrimal duct obstruction. Nasal endoscopy, as we all know, has transformed the approach in CNLDO with the case-based approach. And this has led to the recognition of these rare intranasal cysts or called mucocele, which are seen primarily with congenital dacryocele. Now, these cysts occur because of the simultaneously common canalicular block functional, which leads to the formation of cyst. These cysts are important because they can cause respiratory insufficiency, recurrence, and also acute dacryocystitis. The larger cysts have been described in the literature and their management has been well documented. But what about these cases of intranasal cysts without the dacryoceles? These cases occur because of the congenital malformation at the lower NLT, which leads to the formation of intranasal cyst. So purpose is to describe the clinical features, diagnosis and management outcomes of these intranasal cysts. It was a retrospective case series. All children underwent nasal endoscopic guided probing. On endoscopic, the cysts were divided either as small, if they are completely hidden beneath the inferior turbinate, and large, if they were seen without the need for the medialization of inferior turbinate. All cysts underwent cruciate marsupialization, and only cases with minimal follow-up of 3 months were included. Coming on to the result, over 4 years period, 34 eyes of 33 children were included. The incidence of intranasal cysts was 12%. Mean age was 18.7 months. And history of prior intervention was noted in 56% of the cases, with probing once in 41 and twice in 15% of the cases. Dacryocyte accounted for 18% of the cases. So I divided based on the anatomical types and the clinicopathologic types. Anatomical into small and large, and clinicopathologic into simple and complex type. SAC atonicity was noted in about 41% of the cases. Now, all children without dacryocele has small intranasal cyst, and all the children with dacryocele has large intranasal cyst. And within the simple type, the small intranasal cyst accounted for 61% of the cases, and within the complex, small accounted for 87% of the cases. And the mean time to resolution of the epiphoria after the probing was delayed in many children because of the SAC atonicity, and success rate was 94%. Now, coming on to some cases on nasal endoscopy, this small simple cyst can be noted on medialization of inferior turbinate, is undergoing to perpendicular incision, which is called cruciate marsupialization, with 45-degree probe tilt test and irrigation of fluorescein fluid. Now, this child having acute dacryocystitis was noted to have small white yellowish intranasal cyst, and therefore underwent drainage and systemic intravenous antibiotics. So now this child, after cruciate marsupialization, the thick mucus was seen over the probe, and on further back and forth movement of the 45-degree probe test, the further drainage of the pus can be seen, suggesting that this child has a loculated intranasal cyst. Now, this case was interesting with having a flat fibrotic intranasal cyst, which can be missed and difficult to identify endoscopically. So to conclude, intranasal cyst can be seen in CNLDO with or without dacryocele. And this is the first study to propose the classification of these intranasal cysts. With the help of the nasal endoscopy, inferior turbinate medialization, these cysts can be identified. And the key factors in management are cruciate marsupialization, customized approach, and 45-degree probe tilt test. Hope we can save many children with this identification of pathology from DCR. Thank you.